Good morning, I'm Swami Iyer, and this is the second day of the SOHO meeting. We have the best of SOHO with Myeloproliferative Neoplasms. I have a great honor of having Dr. Serge Verstovsek here with me, the professor at MD Anderson Cancer Center. Dr. Verstovsek, welcome.
My pleasure. Thank you for having me.
So you had a great session this morning, and one of the biggest things is the evolving biology. And before we get into there's so much excitement that's going on there, I would like you to quickly jump into the changing biology of one of the very common myeloproliferative neoplasm, which is Polycythemia Vera. Where are we with the biology, and more importantly for the community physicians and the clinicians, the classification?
Yes, indeed. Polycythemia vera is the hot topic these days because of the clinical implications. I think we need to connect the two together. We're not learning about just biology, and biology appears in Polycythemia vera to be relatively simple comparing to myelofibrosis. High activity of the JAK-STAT pathway, either because of the JAK2 mutation, classic V617F, or JAK2 exon 12, perhaps here and there a case of calreticulin-driven Polycythemia vera, published recently, but driven in general by the JAK-STAT pathway and amenable to different therapies, hydroxyurea or interferon as the first line. Development of a long-acting interferon in particular is of significant excitement, and then approval recently of JAK inhibitor ruxolitinib for second-line PV. What we realized through this process is a need for identification of proper patient groups, development of criteria for a failure of a therapy, development of criteria for response, including response, for example, in the symptoms, which was not there before. But now we are coming down to diagnostic process in Polycythemia vera, and we had a very nice plenary session by Dr. Passamonti from Italy saying that there is planned or proposed a change in the diagnosis of PV, which is, I think, clinically relevant. What happened is that many patients that may have a high normal hematocrit or hemoglobin, or even above normal, may not reach current standards for diagnosis of PV by WHO classification. And they may not be then properly diagnosed as having a PV and still suffer from the circulatory effect of having too many red blood cells. There are always some clues to that, like very low or undetectable erythropoietin, or low iron, and MCV might be low, but one needs to remember those things. And many of these patients are, at this moment in time, perhaps diagnosed as having ET, high platelets with high normal red blood cells. Nobody really pays attention to red blood cells, focusing on platelets. And yet, this is a significant issue. We call this masked PV. So the implication is that these patients should be treated as a PV, have hematocrit lower below 45, because their cardiovascular problems are significant, and at least one study suggested that they may have even worse outcome. Others did not show that, but we all agree that these patients actually have a PV, but diagnostic criteria does not allow them to be recognized as such. So WHO classification of neoplasms suggests that we lower the threshold of hematocrit from very high, 18.5 to 16.5 for male and 16 for female, and change the way of a workup for a PV. Mandatory bone marrow biopsy, hypercellularity would be leading toward PV versus ET, mandatory molecular testing for JAK mutations, and having high red blood cell count at a lower threshold, bone marrow and molecular testing is three factors that one would like to do. And then erythropoietin as a minor factor. So significant change. Perhaps we'll have an increase in the number of patients with PV diagnosed in next few years.
That's good to know. I guess the big take-home message was just 3 points, and eventually we'll see the change happening. But until then, those who get diagnosed with the higher thresholds are risk stratified and offered different treatments to lower the vascular complications, aspirin, hydroxyurea, etc. How do you navigate in those patients who have a clear-cut definition, and of course the ones who have the masked PV, in terms of therapeutic approaches?
So we are still using classic way of assigning the risk, age over 60 or history of thrombosis. those that fulfill either one have a high risk of thrombosis and require phlebotomy and aspirin and cytoreductive therapy to control the red blood cell count, hematocrit, below 45 all the time. There was a prospective randomized study with that goal to prove that maintenance of hematocrit below 45 is advantageous for patients, decreasing risk of thrombosis, so-called CYTO-PV study, published 2 years ago in New England Journal of Medicine. That is standard practice. What happens with development of new drugs is clarification of a patient outcome based on a response to the frontline therapy. We used to say, okay, we can actually control everybody with hydroxyurea or interferon, but that's not the case. It seems that about 10, maybe 15% of the patients are really resistant or refractory to hydrea. And the experts in the field came up with a certain criteria that perhaps are not validated fully, but identify patients that have a poor outcome because they don't respond well to hydroxyurea. And for these patients, now we have a ruxolitinib, a JAK inhibitor, approved. And the significant is that these patients actually have a poorer outcome. They have a higher rate of a transformation to myelofibrosis and poorer overall survival even. So although percentage-wise, perhaps within the PV community of patients, this is not a large problem, but these people are in trouble. They need a new therapy.
So how do you identify? I think that's the key clinical question, and given the label that there is for the hydroxyurea refractory or hydroxyurea intolerant, how do you identify these patients very early on so that you can offer the right treatments?
Well, we would not unfortunately have one genetic test or something novel to that regard. It would be standard way of assessing the benefit by looking at the dose. Experts in the field said that we would try to improve the therapy by increasing the dose to at least 2 grams per day of hydrea, if tolerable. And if that doesn't work over 3 months in controlling the red blood cells, white cells, platelets, symptoms, or spleen, to make it simple, that would then mean possibly resistance. Or if the patients have a lowering of the red blood cell count, so myelosuppressive effect of that hydroxyurea, despite the very low dose, developing very low platelets or white cells, that would be also not accepted well. It would not be acceptable well for continuation of such a therapy. So these patients are the one that we talk about.
And with the Jakafi, of course, you have the study responses, which had a very impressive in terms of many parameters. But the biggest benefit you get from this, other than the survival benefits, is the bone marrow changes with the ruxolitinib in these patients, correct?
Your point is out very well, but immediately what benefits the patient is really control of the red blood cells, white cells, and platelets. In my view, what now, luckily, I would say, or to say my enthusiasm about that is high, is also a recognition of improvement in quality of life with the JAK2 inhibitors. That's very important for patients because they do live longer with this disease. So improvements in the numbers, the spleen, and the quality of life by controlling the symptoms. Whether the bone marrow improvement over time will happen, like we have seen now with the long-term efficacy in myelofibrosis, is something to discover as we follow these patients. On the other hand, what is important to realize is, and it was published actually as a safety item, is that it appears that ruxolitinib does decrease, in fact, the number of cardiovascular events. So that was a randomized study that you mentioned, a response study. Patients with resistance or refractoriness to hydrea were randomized to ruxolitinib or best available therapy. And within 32 weeks of comparison, there was significant difference in the events of cardiovascular thrombosis or bleeding between the two are much less in ruxolitinib, which is in fact the ultimate goal at the moment for any therapy, to decrease the risk of thrombosis.
So we have great options for PV. Just to shift gears, and the other excitement, of course, is the myelofibrosis. And before we get to the therapy, again, there are lots of discussions and thoughts on the evolving mutation landscape in myelofibrosis. So where do you see the field moving to?
This is rather fascinating. I would say every 2 or 3 months there is another paper with another mutation, or analysis of impact of a mutation on myelofibrosis and how does this correspond to one phenotype or another mutation or another clinical characteristic. In fact, one may get lost just trying to follow up these features and these publications. So to make it perhaps simpler to understand, we would say, as we already highlighted, that JAK-STAT pathway hyperactivation and activity is the bottom line problem. Now we can divide mutations that we know of within myelofibrosis to those that activate the JAK-STAT pathway, so-called driver mutation, that are usually exclusive of each other, and it's good to test for them because they help in diagnostic process. The JAK2 mutation, calreticulin mutation, and MPL mutation, or MPL. Now, there are many others that are not exclusive of each other. They may be present to different degree in different patients. They may be acquired. And you may have patients with 1 or 3 or 5 or 7 mutations at the same time during their lifespan. These are mutations usually associated with epigenetic control of the genetic transcription and the splicing of genes. So there are many of them, 25 plus. I mean, the number is just growing. And among them, there are some that are possibly detrimental. Among driver mutations, the calreticulin appears to be a good one. But among these other ones, there are some that appears to be bad. And attempts are being made to combine all this information together. Molecular international prognostic scoring system, clinical characteristics and genetic together. One would argue we need karyotype as well, cytogenetic information, which is hard to get sometimes. But anyway, people are combining things together. But then we ask a question, how is this going to affect our practice? Prognostication is useful for decision making in the transplant area. Younger patients, low risk by conventional means, having the genetics, maybe these patients require transplant sooner. Otherwise, unfortunately, our prognostication and genetic testing are far outpacing our ability to treat the patients with different medications. Only JAK inhibitor is available. And there is no effect confirmed of a genetic background so far. Perhaps if you have 3 or 4 mutations, that may affect the utility of JAK inhibitor. But by and large, genetics do not affect the utility of JAK inhibitor so far.
Great points. Could I just ask a question on the driver mutation? I think there is about 10 to 15% of the patients who are now we're calling them triple negative.
Yes, we always joke about triple negative because that has been used in some solid tumors in breast cancer as well. So the JAK2 mutation, calreticulin and MPL are exclusive of each other and cover about 90% of the patients. So there are some patients that don't have any of these. And these are patients with more aggressive disease. Is it because there is some other mutation that we cannot identify so far? Is it the biology completely different? How they come to myelofibrosis? Are we missing something? Are these overlap syndromes with the MDS or something like that? It's hard to say. There are not too many of them, 1 in 10. But it is known that these patients don't do well, and that would be one factor in clinical practice to consider when you talk about the transplant. The clinical utility of this beyond the transplant is rather low, but the clinical research, which is another topic, is bringing us many new exciting drugs. So hopefully within the next 5 years we'll have more choices.
Excellent. And so, but for the more day-to-day community practice, we still use the DIPS plus scoring to identify the risk.
There are international prognostic scoring system for the beginning at the time of diagnosis. The same 5 factors which we discussed you can use later during the disease course, dynamic international prognostic scoring system. Here, one cautionary note, the anemia in dynamic international prognostic scoring system weights more as a bad factor than the others, but it needs to be disease-related, not therapy-related, right? And the DIPSS Plus that you mentioned also incorporates low spleen, transfusion requirement, and bad cytogenetics. One or the other, any of these is good for guidance, particularly for transplant decision-making, but otherwise for utility of JAK inhibitors or any other therapy, unfortunately not yet. Hopefully we'll have more choices soon. But
so for the vast majority of the patients who do require treatment will go on a JAK inhibitor.
Well, the JAK inhibitors are given to patients, I would say, for control of the symptomatic splenomegaly and control of systemic symptoms, body wasting, aches and pains, night sweating, low-grade fevers, fatigue, and others. They, by and large, with perhaps some exceptions, which is not proven yet, do not improve the blood cell count. They should not be prescribed to patients just because patient is anemic to improve the count. In fact, they may lower the count, right? Myelosuppression we talked about is a side effect of ruxolitinib. They should not be given patients just because they have a disease and are not having any other symptoms or signs that interrupt patient's ability to function or compromise the quality of life. That would be my view, to treat the patients that have symptomatic organomegaly or symptoms from the disease otherwise constitutional. That is a large majority of the patients, but we need to develop urgently medications for anemia, for thrombocytopenia. We don't have medications for that that are successful at all.
And I'll come back to that point in a second, but just want to dwell on those patients with disease burden, symptoms, and who are on the ruxolitinib. And one of the things that came out of your presentation today as a prognostic factor, other than the mutations, is the splenomegaly reduction. Could you elaborate on that?
Yes, I usually get two questions, not just from the doctors that I interact a lot, but the patients before starting ruxolitinib would like to know what is it that they would project whether they would do well or not. In the most recent analysis that was just published a month ago, we found, actually talking about genetics, that 3 or more genetic abnormalities in these patients, and we studied about 90 patients. If they have 3 or more, they don't tend to do well on ruxolitinib as others do. They do respond, and they have some improvement, but it doesn't last as long as the other majority of the patients. I don't think that's something that we should be using in everyday practice. It's exploratory, needs to be confirmed. But other aspect that you are asking about has been confirmed in 3 studies so far, that during the therapy, and that's the only factor so far that I know of that was shown on therapy to predict the outcome, is the response in the spleen. So the better the spleen response, the longer the therapy lasts and the longer people live. So I am always emphasizing this in my presentations because it's proven in 3 studies so far, and it's such an easy factor. You can measure the spleen. It's not genetics, it's physical exam. You feel the spleen, and it is related to a dose of the JAK inhibitors. The higher the dose, the better the spleen response. So I tell people, don't be shy using the higher dose at the beginning, as it should be according to the label of the drug, because to start with lower dose, just not to have any myelosuppression, may impact on the ability to have a very good spleen response, and then the overall benefit doesn't last that long. So spleen response for me, saying many patients with myelofibrosis, is a very important factor during the therapy with the ruxolitinib.
So it's very important that you persist with this treatment, and even though you are able to focus on managing the anemia and the thrombocytopenia. So obviously the post-Rux, I mean, there are a lot of patients who do benefit from it, and then the post-Rux, patients who fail or progress through ruxolitinib, there are all these, we thought there was nothing out there, and then suddenly there are a slew of JAK2 inhibitors, or JAK1, JAK2 inhibitors, and then other agents, especially the one that you had this abstract presentation, the plenary abstract presentation, the PRM 151. And that seems very exciting. Could you talk a little bit more about that?
Yes, so ruxolitinib duration of therapy is about 3 years. Other JAK2 inhibitors, momelotinib and pacritinib, are in phase 3 studies for frontline or second-line use, and maybe they're able to bring additional benefit, improving the anemia, like with momelotinib. We will see. Hopefully we'll have more than one approved.
If I could just ask you, what is the differentiation point for these 2 agents with respect to ruxolitinib?
That's the tough one, because the momelotinib and ruxolitinib are JAK1 and JAK2 inhibitors. Perhaps there is a difference in how they affect, to what extent one or the other, because JAK2 is more involved with the proliferation, JAK1 is more involved with inflammation. So one is maybe a little bit more myelosuppressive because it's anti-proliferative. The other perhaps is a little bit more anti-inflammatory. That would make the red blood cells to improve, because inflammation is a very important part of the disease biology, not just uncontrolled growth of the cells, but the inflammation that comes with it, all this cachexia, bone aches and pains, night sweating, that's the inflammation that comes with it. So it's not quite clear, but suggestion is that momelotinib may be able to improve patients' red blood cells to make them transfusion independent. So maybe we'll have more JAK2 inhibitors, but after JAK inhibitors, patients are again faced with the inevitable outcome, because there is nothing really to do. And life is short, unfortunately, and it doesn't end in a good way in terms of suffering is there and bad quality of life. So new medications, and two medications actually are very hot these days. This is imetelstat, telomerase inhibitor. Two papers published recently in New England Medicine showing that perhaps even in a very small group of patients, but nevertheless, maybe it can actually eliminate disease for a duration of the time. We are talking about few patients having a complete response and few patients have a partial response. This now needs to be verified, and the large 200 patient studies being done across the globe to confirm these initial results. The drug does cause some myelosuppression and some liver problems, but nevertheless, enthusiasm and interest is there. And the other one is PRM151, antifibrotic medication, which is the recombinant protein that we make in our liver. It's called pentraxin-2, that controls differentiation of blood cells called monocytes into the fibrocytes, fibers that are originating from the blood cells. That it seems to be actually involved in the fibrosis in the bone marrow of patients with myelofibrosis. The suggestion is from some preliminary work also presented here at SOHO yesterday morning, is that the large part of fibrosis in the bone marrow of patients with myelofibrosis is actually part of the disease process. And these fibrocytes, they look alike like fibroblasts. The fibrocytes, hematopoietic origin cells, are malignant and part of the disease. And with this medication, PRM151, which is controlling differentiation of monocytes, you potentially can reduce the fibrosis and improve the bone marrow function. And today we presented the update of ongoing pilot study in 27 patients that the longer you treat the patients, and it's given IV once a month, the better appears to be getting in terms of ability to decrease the fibrosis and improving the platelets, improving the red blood cells. As we said, these would be clinically certainly unmet areas that there is nothing to provide the patients. So completely different focus, telomerase inhibitor, antifibrotic medications, but very exciting.
And clearly, we're finally making dent into the biology with starting with the JAK2, JAK1, STAT pathways, and now with the telomerase, and then with the PRM1. And hopefully, with all these changes in the biology, how about the question of transplant? And obviously, we're still going to use conventional methodology like the IPSS and the.
So it's realistic to expect with other medications, unless there are some surprises. For example, with the imetelstat, we certainly need to confirm that there are some patients that are cured. But realistically, we would be able to control the disease in a better way than JAK inhibitors with these new medications, make it livable for patients for much longer. Transplant always stays the one that can actually cure patients in a large number, but it is risky and it's not for everybody. What happened over the last 5 years in myelofibrosis with the transplant issue is that the age limit has increased. At MD Anderson, it's up to 75 years of age because we are able, in doing the procedure, decreasing the risk, but the risks are still there. And we don't really know long-term outcome of these patients with the techniques and the approaches that we have right now. But we are also able to make people more eligible for the transplant with the use of JAK inhibitors. If we decrease the spleen, improves ability to walk. So the approach to combine the JAK2 inhibitors with the transplant is something that makes sense, and perhaps at the beginning we were hesitating to combine the two together. But now we just had the pleasure of reading a paper in leukemia about 2 months ago where there are even guidelines from the transplant community on the use of JAK inhibitors before transplant, suggesting that the patients that have a donor but have a tumor burden that affects them, bad quality of life, poor performance status, big spleen, should be actually treated with JAK inhibitor for 2 or 3 months at a higher dose, 20 milligrams twice a day, even with the blood support, transfusions, and so on, to improve their condition and get them to the transplant and treat them up to the end, the day before the transplant with JAK2 inhibitors, because 3 studies so far showed, and today that was also highlighted, that after transplant, those patients that have excellent response to JAK inhibitor before transplant do much better. So I think the two needs to be combined. We'll have a better success with transplant, and more patients will be transplant candidates.
These are great points. One of the things all these things bring out is the complexity, not just the disease, but complexity of the care. And I want to sort of give a shout out to the patient support group and that you and several others have been leading, and also the multidisciplinary approach. And for several people in the community, it becomes much too complex to handle all these different, let alone trying to understand the biology. Would you some thoughts on the multidisciplinary approach, and of course working closely with the academic team and also with the transplant team?
I think you made a good point. We started with the genetic complexity. Okay, that's complex, but perhaps not really that has a much input at the moment for the clinical practice, but to manage the patients which can present in different ways with different clinical problems, to know which agent to, for how long, at which dose, which study, if the study is available, and how to get the transplant done in best possible way, including JAK2 inhibitors, not providing transplant at all. All these issues are complex, and knowing that this disease is very rare, and one doctor in community setting may see just a case or two a year, because we are talking about 3,000 new cases in United States a year, so it's very rare. And having just a handful of patients to see, perhaps one really needs to reach out and have a team effort to manage the patients in a community setting. So it's not unreasonable to have a consultation done, and we do this very often, communicating with the referring doctors, and really in a true sense of word, having a team effort with the transplanter, with the expert myeloproliferative disease expert, and the community doctors working all together for the benefit of the patients. It is complicated, but it is all for the good. The patients have a better choices, better outcomes, and we are making progress.
On this note, I think I would want to wrap up this very good summary of the myeloproliferative neoplasm session. It's not just complex trying to understand the biology, but also complex trying to navigate the patient, and we'll better pay heed to the advice Dr. Verstovsek said about multidisciplinary approach. And yes, there's more things coming in the future. And Dr. Verstovsek, thank you very much for all that you've done.
My pleasure. Thank you very much.